Oh, hi guys. Welcome to Dr. Luke, Heart to Heart with Luke. And today we're going to talk about diminished ovarian reserve. And now let me again figure out something interesting on my page, something pretty different. So this page, I it's like a little different setup. Right, a comment. Hi. Okay, so I see comments coming in, but it's now different from last week. Sorry, again, bear with me. I'm new to this. And oh, everyone, okay, now I see things I see more similar. Updated link. Oh, I don't know what's the updated link. Someone help. I think uh okay. Okay. Very good, very good. It seems like everyone is able to check on. Because I actually discover something about Facebook. You can have an account, but then there's different pages on the account. So my account somehow included Gen X page. So I didn't know there was a difference between Gen X and my own web page. Ha! I'm learning something new. Facebook 101. I didn't take that when I was in medical school and college. So that was me. Um, so my helpers, I have to get my family members as helper to help me get a piece of paper. We're going to talk. Now, I thought we are going to talk about this in a more like a lecture kind of way, but I thought it may be even more fun just to write things on a piece of paper. That's what I'm doing nowadays at home. I use my children's color pencil, and then I draw things. And so because I like to draw circles. Yeah, circles equals eggs. So that's what I'm going to do. And nowadays I do lots of pre-K math, pre-kindergarten. Oh my, I don't know. I do involve with my children's education. I love education. That's how I pay myself tutoring students and help myself through medical school. Not cheap medical school. And I love educate. I tutor high school kids, SAT, physics. I used to drive down in Connecticut in some towns where I tutor physics and biology. So I do lots of teaching since I was a little younger. I'm kind of rambling now, but basically, I just learned now how the kindergarten and the setup here because my half of my education was actually in Hong Kong. Half of the education was here. So I immigrated here when I was in fifth grade. But then I went through sixth, seventh, eighth, middle school here. Some of you may not know, but I was a basketball player. So I was going to get into New Jersey State. That's where I immigrated to, is New Jersey. But then, due to many social circumstances, my parents moved back to Hong Kong. And so I got both middle school education here and American education in Hong Kong during my middle school and high school years. So it was very interesting. Hi guys, hi everyone. Oh, so sweet. I see patients even from, I mean, not patients, excuse me, like for old friends from a long time ago. Now, I last time I was able to invite people, but somehow this time because my families don't usually like to hear like my extended family like me lecturing about biology, but they said they were very interested. I have like my cousins, my nephew, so I was very excited. Um, Okay, yes, I will. I will talk all about that, the timeline. I know you guys post very difficult questions. Always challenge me. I'm always challenged every day. I thought I would take my final exam in medical school, my board exam. I said that's the toughest exam. That's it. But then life, and I bet you guys all, each of you have lots of life challenges now. COVID, curveballs in life, right? Yes, but we're going to hopefully win. But yes, I will try to answer some of your great questions here, and I'm going to write this down. Time to restart. I know, difficult questions. And time to embryo transfer. I got a great question yesterday about that. And as some of you may know who are my patients, I cancel lots of transfers and lots of, you know, because of COVID and safety reason and so forth. So, okay, bear with me. I next time. By the way, I chose a music piece. I thought in the beginning because sometimes I'm running late. You guys are running late. We can do some music. What do you guys think? I'm going to put on a option in Instagram, like a first 5 minute just music, waiting for everyone to join us, um, and so forth. Oh, and I have old time friends and or patients say, "Hey, I'll be oh so sweet." Oh, I never, I never think about. Now I think it's public, right? You guys can see everyone posting, right? Even my old medical school students. I guess it is, right? I guess I can say. Let me see. I say hi. Will you guys see it? Is it public? Like when I say hi, everyone see my thing? Oh, I think so. Okay, wow, you guys asked me lots of questions. Okay, I need to cannot keep track. But we're going to talk about diminished ovarian reserve first. I'm going to talk about ovaries, and I'm going to focus on this topic because this is my passion. The beginning of Generation Next and the beginning of me really want to do something a little bit different is really because of diminished ovarian reserve. Now, give me one more moment. I'm going to just figure out my Facebook homepage because I need to invite someone. Now, I know all of you screaming at home telling me where to go. So hold on. Let me get my assistant. My assistant help me out because Dr. Luke does not know what to do. So hold on one moment, guys. Sorry. I just need to find out what I can because last time I was able to. Great question. AMH discrepancy with FSH. Wow, you guys are very smart. Great question. Hold on, guys. Let me ask this. Hey, hi, my beautiful assistant. I think we're on live right now, and just wondering how to invite groups. Last time I was able to invite groups. Can you just yeah? Last time I was like able to invite like my family, like everyone. How do we share that? Like different groups, like mommy 40, things like that. Can you figure out? Thank you. Can you go on? Thank you. Sorry, didn't mean to give you behind the scenes. I just don't know what to do. Last time the framework was much easier, and I just check, and now I don't know where I am. So let me focus on this. Hi, one more time. This is Facebook Live, and some of you may not sign in last week. Didn't know this, or never heard this. I'm not very good with Facebook and Instagram. I really introduced this in 2020, and some of my younger staff tell me, Dr. Luke, it has been around since the early 2000s. So I'm a dinosaur. So I apologize. Those years I was in medical school, trying to learn about the ovary, so not very well averse with, well versed with technology yet. So sorry about that. In any case, I'm very excited with COVID-19. See, anything comes with risk and comes with opportunity. I got opportunity to talk to you on a random Tuesday afternoon at 2:19 p.m. Usually I'm talking to patients in the office. Now I'm talking to tens of you at our Facebook Live. So I am going to talk to you a little bit about ovaries first, ovarian physiology. Then we're going to go into ovarian reserve. So I'm going to draw some circles. I have a little piece of paper here, and hopefully you guys can see. I'm trying to get a better pen. That's why I'm okay. Hold on, guys. So, when patients are usually, I'll tell all my medical students when I was taking history, and I want you to understand because right now technology is very focused in numbers. What's your AMH? What's your FSH? And I and this is where I learned when I was from a very senior doctor and so forth, the best diagnosis that you can make. And most of the time, I can make a diagnosis already inside the room because 80% of the information is right there. And so I listen to the patient, listen to the stories, and try to synthesize in my brain, what are the things I need to focus in? How can I counsel this patient? What can we do to benefit her? Or what can we do differently if she fails somewhere? Or even I failed her last cycle. What can we do differently this cycle? What are her ovaries like? I always call myself an ovary whisperer. It's kind of weird, right? But basically, I'm listening to the ovary. The ovary is very different every month. And the ovary is not really like testicles. So ovary changes dramatically from the 20s to 50. And you should know, right? Because most women menopause at around 51.7 years old. So ovary doesn't is not stay stagnant. Um, yes, I know. I'm not trying to talk about sperm quality, I'm just talking about in terms of ovaries changes, the way she reacts, the way the ovary will produce a baby, the chances to produce a baby, the good and bad eggs, which I'm getting into in the moment right now. Those are very interesting in terms of how do we how do we know what the ovaries is like in April 2020, or how do we know what the ovary will be like in the coming months? Now, the ovary is also there's no like a distinguished number or a temperature thermometer to it. The only number that you have is FSH and AMH. So then lots of people were like, well, what's my FSH? What's my AMH? And that will predict can I get pregnant or not. Actually, it's not. AMH and FSH are only only numbers that really predict your quantity. Quality really stays still with age. And we can do anything we can to try to manipulate the FSH or AMH, i.e., quantity, in certain extent, but we cannot really affect quality. Quality, I know some of you may ask, well, doctor, what about eating a healthy habit, having a healthy habit, eating healthy? What are your patients who are a little bit older, let's say 44-year-old get pregnant? How did they do it, Dr. Luke? Very interesting. I do believe in a healthy diet. Recently, I'm not very healthy. I've been eating lots of chips and chocolate. I don't know if any of you at home are doing that, but it's really hard. Like I watch the news and I'm like, oh, so many people. I just keep on eating sugarish stuff. I don't do that. I feel so guilty, but I want to share my guilty feelings with you. I'm gaining lots of weight too. But anyway, I just eat lots of, so try not to do what I do right now, but emphasizing on greens. And I'm not a big cook, but I do not like lots of fried food. And I do drink lots of soup, and I think it's my culture. I drink lots of soup. Fluid is something very important for me and very important for some of my patients. And they do carry out sometimes. I haven't. I'm not a cook, and I was thinking about doing something cooking with you guys and not good with cooking. That's a different story. But in terms of the ingredient, I really believe in you are what you eat. And this is actually one of my nutrition classes back when I was at Cornell. And it was a nutrition 101. And the first statement that the professor make is you are what you eat. So I do believe in the healthy diet and hopes that we can change the quality of the egg. But again, there's no magic pill where you take pill A, then you get a great, get a fantastic egg. There's nothing like that. I will, in this kind of downtime, when my office is not there and they'll half closed, but I would love to share with you some of the data on some fertility sterilities journal and also on some of the supplements that very commonly used in the community, New York City, as well as in patients. So we can do that next time because everyone is asking me about supplements. Okay, so Let's look at the ovaries. And we're going to talk about diminished ovarian reserve and basically really about education about ovarian quantity from different parts of my lecture today. So this is just first part. We can do that again on Thursday. I'm going to repeat myself. Some of you may be like, oh, she's repeating, but I'm trying to make a new point when we repeat. And learning is repetition. So I'm going to keep on going back about some of the things maybe I'm not clear about the points I'm making. And then maybe you hear it differently. It's like you're reading a book. When you read, I always read my old textbook, even sometimes during journal articles, we read it different times and may get it differently. Especially medical knowledge is if some of you are not in the medical field, or it is sometimes difficult to understand the first take. So you will hear me saying it again and again. So the ovary, I'm drawing a green ovary. It's not unintended, but uh, do you see the ovary? Yes. So that's an ovary, and you see the loose circles around it. And let me see. Yeah, sorry, camera. So those are loose. One, two, three, four, five. One, two, three. Yeah, six. So I drew 6 circles on loose circles in the ovary. And what the point I'm trying to make is, if a patient has a actual follicle count around this, and it was about 6 on each side, in a patient who is between the age of 27 all the way to, I don't know, 35 or 36, that is around the amount of eggs usually one has. And the AMH is usually fluctuates on each ovary. So I always use the number 10. It's easy for one to compute, but usually is between like the 10 is the average number, so between 8 to about 13 or 15. And some patients even surprise me, they have 10 on each side during their late 20s, and then slowly it would decline as you age at 35 and then 40, it will decline. It never increase. It may stay the same, but usually does not increase, whatever that reserve. And we call this an ovarian reserve. Yes, ovarian reserve. So when you come to see me, Dr. Luke is going to ask you about history. And one of the most important history for me is menstrual cycle length and menstrual cycle days. And also age, obviously, but I don't need to ask. Usually you write your age and I kind of know. And in my mind, I will already have a categorical, like to know where you are. Are you 44 versus 30 years old? How long have you tried? Those are the questions I usually ask from you. Then majority of the patients say, Dr. Luke, how good are my ovaries? And so then I would say, well, we're going to check some blood work, something called anti-Müllerian hormone, AMH. I'm going to write this down. And our webpage is going up on this lecture in about a couple of days. So give me one more, because we're trying to make the graphics, but I already written the webpage. I always wanted to talk more about AMH and FSH because it is a confusing number. It's also sometimes anxiety provoking. I heard patients sometimes I don't know, vans, people check AMH and they haven't even seen a doctor. They will check a laboratory number, and the patient, let's say, have a lower AMH, they get so scared and they will run to my office. So I'm trying to provide more information on the website, so you don't even have to see me yet. You can learn a little bit more good information. So I'm going to put that. You can put that so you can read more about it. Okay. So AMH is called anti-Müllerian hormone. AMH. Okay. Someone I go on. So that messaging. Okay. Okay. Good. So it's all accomplished. So AMH is anti-Müllerian hormone. It is a hormone marker that is produced by the granulosa cells, which is some cells that are surrounding the egg. Some of you may know I also do egg retrieval without anesthesia. So some of you may have seen an actual egg during egg retrieval when Dr. Luke was doing a procedure. Then we're, oh, that's an egg, and I will usually say, hey, can you show the egg to the patient? And if you haven't done it, that's okay. Next time you request it, we can even take you pictures of your own egg. But there's a oocyte here, and there's some cells that are surrounding it, and those are called granulosa cells. I also are contemplating I would love your feedback. I know you guys on Facebook Live or on my personal, you have J.Luke at Generation X Fertility or Connect. If you also want a more lecture, I can also do Zoom in and then invite all of you on it and like a discussion session, which I'm planning on doing. See, I'm learning technology. So that will be much better instead of me using a FIS and granulosa cells, so I can show you pictures. But I thought PowerPoint will be a little bit boring because when PowerPoint lectures are not, engaging. So I thought maybe we'll do this way. In any case, so the egg and there's granulosa cells. The more eggs you have, ideologically, the proportional granulosa cells also increase. So the more eggs you have, AMH will be higher. With FSH, it is a hormone produced by the brain. So when your eggs, so there's a feedback loop with the FSH, and so that's another marker. So let me introduce one more time. 3 ways to understand your ovarian reserve are the antral follicle count, AMH, and then FSH. Those are the 3 markers telling us how good, how bad, or in terms of, actually, no, how many are your eggs, not how good is your quantity, but not quality. Okay. I will explain now what's FSH. Again, it's a hormone from the brain. It's a feedback loop. It's like right now it's lunch. You haven't eaten lunch and you're hungry. The hormone from your body will give a feedback to the brain, say, hey, it hasn't eaten. It's lunchtime. So there's a hormone that go back to your belly and says a growling and moving because the hormones is trying to say, hey, you need to eat. You're getting hungry. And so the FSH is also another feedback mechanism. The FSH is a hormone produced by the brain. So if your ovary is getting quieter, less eggs, the FSH then will go very high. Why? Because it's a feedback mechanism created by nature. If your body is doing something extreme, then the brain will try to keep it going, right? So, for example, if you're eating and you're getting full, your stomach never can explode because your stomach is going to give a hormone to the brain to say, hey, stop eating. You're full. So don't stop putting things in your mouth. You're full. So that's a feedback loop that the brain has. And so with the ovary, the same thing. If the ovary is not producing lots of eggs or have trouble doing so, the brain will be like, ovary, give us some eggs. So then it will increase the FSH and change pushing the eggs, getting the ovary to produce more eggs. So the higher FSH, the more a marker to tell us how good is your ovary. So if your ovary only have 2 eggs, the brain knows, oh, she needs some help. Let's yell at the ovary more so she can produce a follicle. So like, yo! And so the FSH is very, very high. When we're younger or women are younger, when the ovary is very active, means have lots of eggs ready to ovulate, the brain is not going to use so much FSH. So the FSH is much lower. And so it reflects the ovarian reserve as well as oocyte quantity. That's why people check the FSH value. And it changes month to month, which reflects the first question is AMH and FSH. Why some months FSH is higher and what's going on with AMH? Now, FSH does fluctuate throughout the month because at the middle of the month, there's a marker where the FSH will go higher with the LH, just a brain mechanism. So if you check it at the wrong time of your FSH in the middle, you'll really scare yourself. You're like, oh my God, my FSH is so high. My ovary is no good. No, 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 no. You just check in the middle. So that's why we always say check your day 3 at the beginning of the FSH so you don't scare yourself. Okay. AMH usually is straight flat. I'm going to give you a list, not today, so sorry, because I don't want, I think that certain things does affect the AMH. birth control pill, sometimes, not all the time, smoking, certain activity does affect AMH, but it is very consistent. And that's why people love using it because regardless where are you in your cycle, AMH is quite consistent throughout the cycle. But again, there are certain things that can still lower your AMH. But I'll give you the whole list next time. So that's my homework. FSH and AMH, both of them are very good markers, plus the antral follicle count, which is counting the eggs in the ovary. Sometimes they do not agree with each other. Oh, so sometimes your AMH may be about, I don't know, let's say your AMH is usually 1.7, and which is pretty good, but the ovary didn't reflect 1.7. So I usually equate about 10 eggs to around 2.5 AMH, around. Again, these are all ballpark, how I think, how maybe other doctors would think, but it's not an absolute. So I don't want you to say, oh, I have 2.5, so I only have 10 eggs. That's not true. I have patients with 2.5. They can also give me 15 eggs. But it's a good way to understand an ovary. FSH can or will fluctuate during the cycle, as I said, and also between cycles. So I have a patient with a 13 FSH at the beginning of the year, and then it was 9 or 10 throughout some months in the year. My God, Dr. Luke, I got younger. It was so high, 13. So it's good. The summer months is good. My FSH is lower. No. For FSH in our body, it's like, I have medical school friends blocking it. But sorry, I need to focus. See, Dr. Luke is not used to Facebook Live, so anyone log in, I start to divide my attention. So I apologize. So FSH, when you are high at the beginning of the year, let's say 13, and now you're 7 or 8, your body is functioning like how you're feeling in life and how humans are. We fluctuate. Such as, I bet there were times during COVID, and some days I will share my feelings. I was so down. I was sad. I couldn't see some of my patients. I do have joy coming in, scan in the morning. I know, nerdy me, but I do enjoy my job. So I'm like, oh my God, I don't get to see you guys. And I sometimes feel very overwhelmed because I've become an elementary teacher as well as pre-K teacher. Yes, I'm the teacher at home doing curriculum. Like I told you, I love teaching. So my kids, yeah, I don't know if they think they're lucky or not, but I do pre-K math in the morning, elementary, right? So overwhelmed. Then some days I feel, oh, I'm not overwhelmed. I'm so relaxed. So what I'm trying to make a point is that our feelings are not consistent every day. Same with our ovaries, same with anything. So if your FSH is a little bit higher at the beginning of the month and your FSH now is 8 on August or July, it only tells me that, oh, your ovary can get to FSH of 13. So we always get the highest FSH as in a marker, not to represent you as in a whole, as in a understanding, oh, wait, Mary, your FSH can be that high. That means that maybe some ovarian reserve diminishing is happening. But it doesn't mean that you don't have eggs. So first of all, there's no extreme. So patients like, and can I get pregnant, not pregnant? That has no meaning about that. Your FSH can be high, you can still get pregnant, first of all, which I'm getting to there, which is one of the major points I want to get to. Second, your FSH can fluctuate between January and March. And yes, I will be alarmed. And I, as a doctor, will be like, her FSH was 13. Compared to another patient where FSH never go high and always at 8 or 6 on day 3 throughout the entire year, then we say, oh, she may be, her ovary may, one patient's ovary may be a little bit more diminished than the other patient. That will be in my mind. But does not mean any prediction as in she can get pregnant and this patient is not going to get pregnant. It has no meaning with that, which can be frustrating because patients want an answer from all this FSH and AMH, but they do not have that kind of absolute meaning. You can get pregnant because of FSH are high. And it also does not have any absolute meaning for that month. My highest FSH for a patient to get pregnant during that month, 1 egg retrieval, and I can tell you patient who have sex too, with an FSH of the highest, was actually a patient who was 25 FSH. So Our patient also come to me, Dr. Luke, I have high FSH. I'm not going to try. I'm not going to get pregnant. No, keep on trying. I mean, not now IVF, but sex. Um, and yes, you can. FSH does not represent that egg is bad egg. Data. I am trying to collect some data because many places, when they see FSH is higher than certain level, will say, go home, come back next month. We'll see if your FSH is lower. And so you guys can hear me, right? I'm so sorry. Someone posted a comment. I got confused. Am I? You can hear me, right? I think you can because people were texting me and saying no. Okay, sorry, got distracted. So I want to kind of look at FSH level as in understanding of as a person as in a whole, but not as in labeling yourself because a number is high. Okay, so then the second thing is AMH. AMH is a great number and not a good number. Um, I guess I can equate this like the weather. You see sun, right? And there was a temperature prediction of today. There may be some gray clouds you see far away, and there's some wind, right? So all these are data saying what is weather will be like in the next couple hours, and also there's a weather, stage, the TV station will tell you what the weather is like and so forth. But what I'm trying to explain is that none of this number represent you as in a whole. But when I see one number, I want to look at the other two numbers to understand the consistency. And if they are both low or indicating that you have low ovarian reserve, then you have low ovarian reserve. But that is also a number. Does not mean that you cannot get pregnant. So let's get back to AMH value. AMH value. So if your AMH is very low, let's say, I don't know, your AMH is 0.5 and you are 30, let's make it a nice analogy, 28 years old. And I have a patient who is 45 years old with an AMH of 0.5. So what I'm trying to make the point is that, not make anyone who are older feel bad or anything, it's just more about the egg quality. The egg quantity, because she is 28, 29, 30, 31, and they still come and see me for IVF cycles, even though I'd say the egg quality holds, they sometimes need help. But sometimes they don't. They don't. I have a patient who is a 35, AMH was 0.08. She was in tears. And at that point, she didn't have a partner. And then after a couple months, she finally we like to use donor sperm. And I said, why don't we just do an IUI? And I know, I don't know if I should tell you all, but she had twins, AMH of 0.08. So, I mean, but her cycles will start to be irregular. And data for this is very nicely done for patients who are very low AMH, getting worse. You can still get pregnant. But the percentage is no longer, if you're 35, it should be 50%, no longer 50%. You may be only about 10 to 20%, but you can still get pregnant. So that's why we're working hard when patients come to me, when they have wasted time, not wasted time, but when they did not get what they want or the cycle cancel with high FSH, then I say, don't waste it, guys. Try still either have sex, IVF, go ahead. One egg, you don't use the number to predict if you're going to get pregnant or not. Dr. Luke, don't you want more eggs? Do you have a patient with 15 eggs? If I'm 30 years old, come to your office, don't you want many eggs for me? Yes, I do. If your AMH is 2.5 or higher and your FSH is low, yes, I never will only want 2 eggs from you. The whole point of diminished ovarian reserve is that, but what if you don't have 10, 15, 20 eggs? You only have 2 eggs or 1 egg. Should you lose hope to have a baby? No, you should not. That's number one point I want to make to that. Number two, yes, age does make a significant difference between a patient who is younger and a patient who is older. Okay, that's my second point. Yes. But don't give up hope because your AMH and FSH or your ovarian reserve are consistently low. Dr. Luke, third point. What if the numbers are not consistent with each other? And that is sometimes can confuse, very anxiety provoking. And that is when I really need to take a history. And yes, when the numbers are not consistent, or you just went to ultrasound, or your primary care doctor just randomly check an AMH and FSH, you don't understand what that means, but you're getting scared and you're not ready to have a baby right now, then I think coming to not only me, but any fertility doctor to explain the numbers to you, an overall picture will be important. Yes, you should then go to see a doctor to understand those different numbers. But yes, they can be inconsistent and sometimes it can be confusing. But I don't want to give you all the different scenarios, how it can be. Maybe next time as a working exercise, so then you guys understand at home. Now it may be difficult to see me, but or your OB/GYN, but I think that's telemedicine. So you can also make an appointment on tele just to understand those numbers. If you had those numbers last couple of months, and you're like, what does this mean? I'm sitting at home, I'm scared. You're always welcome to make those telemedicine phone calls. Clomid is a very good medication for patients with decreased ovarian reserve, because if you do not have lots of eggs in your ovary anyway, I always use ping pong balls in the bag. So no matter how hard you shake the bag, you're like, well, I want more egg. Well, there's only 2 or 3 in the ovary. If I give you double, I pour those expensive injections, Gono-F or Menopur, on your ovaries, it's not going to suddenly give me 20 eggs. It's only that you, not that you wasted money, but you did use all this money to buy all this medication. You may not have that result that we want. So Clomid is great, but you have to know how to use it. And again, FSH changes each month. So you cannot give the same dosage. And I learned that the hard way in my past, and also with different patients. Sometimes I have to test it out. And even a little bit Clomid, it can make the brain produce lots of FSH. And sometimes it's too much. And you can drive the ovary in a shutdown mode. So again, this is a little bit difficult concept, but basically Clomid is a medication that tricks the brain to produce the FSH. The FSH is the same medication, it's similar, not exactly the same, but that's how human beings produce FSH. You know, those Gono-F recombinant Gono-F pens. Some of you may have used $2,000 to buy it, or $1,000 to buy those FSH expensive medication. That FSH is similar to the compound that the brain is producing. So when the body is producing FSH, it is similar to what those injections are. So ironically to say, if your brain is have an FSH level of 20, that means you are kind of injecting yourself equivalent of around 225 or 150 of the international units of those Gono-F pen. Interesting, huh? So if your brain is already giving yourself 225 FSH levels of international units, then the ovary may be already being pushed. So why are you giving your ovary 225 more? So that's my argument also. Why giving her more? Because the ovary is not going to respond. There's only 2 or 3 ping pong balls in the back. No matter how hard you shake the back, there's only 2 or 3 ping pong balls. So that's also one point. Second point, you guys were asking me, Clomid. Clomid is a medication that stimulates the brain to produce FSH. But if the brain is already on high drive, means it's already like pushing the ovary very hard. You're tricking a brain already doing it, and giving Clomid can drive the brain even higher. So the FSH can go up to 60. 60 is no good FSH, because now if you do that and the brain accidentally does that, then the ovary would not respond with a 60 FSH. Why? This is more the mechanism of FSH receptor and the follicle, how it works. It is a little bit complicated, but basically if you give your ovaries sometimes too much FSH, and some of you who have done cycles that are conventional cycles, means that you have injected yourself lots of medications, some months it may work that you will have a response of 5 or 4 or 3 eggs. But some months you use so much FSH and medication, and the doctor may say, hey, there's only 1 or 2 eggs, let's convert to IUI. There's only one egg. Let's convert to time intercourse. Let's cancel cycle. Let's not spend so much money on a cycle. There's only one or two eggs. So that is the same concept. Is that your ovary didn't like that overwhelming FSH that came to the ovary. And to understand this is very basic science. Sorry, I love to talk. So I told you I was not going to teach you because it's complicated, but it's very simple understanding. That every of our cells have receptors. So right now I'm touching my hand or you're touching something, you feel something, right? That's a receptor. That's how it feeds a neuron from your arm to the brain, telling your brain, oh, you're touching the desk. And if I hit my arms very hard right now on the desk, it will be painful, right? The pain receptors will say, oh my God, Dr. Luke is hitting her hand really hard, and will send a signal to the brain, and the arm is built with a mechanism. When you hit it very hard, there's some signal called pain. So you will not keep on hitting your hand, so you will break your own arm, right? So that's how your body have a constant feedback mechanism to every part of our organs to protect yourself. You eat, you will keep on eating, but you will stop. When you're having a period, you also will stop having a period. You know, keep on bleeding. When you go to awake, I'm not going to be awake until 5 years, right? I will go sleep. So there's a feedback mechanism keep on happening. And how do the brain and body have a feedback mechanism? Isn't it beautiful? That's why I love medical school and love being a doctor and love the body and the ovary. It's just a beautiful circadian rhythm, cycles that the body just keep on having a feedback. And the ovary is the same thing. Is that there's a feedback and there's a receptor. When the signal is too high, what happens to the cycle or to the cells is that the FSH receptor will go back in, go away. Okay, they will not able to sense anything. The receptor will, when there's too much signal, it's not just the ovary, any part of our body. When there's too much signal, the receptor will go back in. They don't want, they can't function because there's too much signal out there. So the regulation of the body is to hide the receptors. So that is another point of why too high FSH is no good. Okay, where else? Let me see that. More questions. Now, I know I'm missing when to restart. It's difficult. It's difficult right now because it is not an easy answer. It's doctor to patient, and lots of decisions are really being made by really safety with COVID, the public safety. There are urgent cases that like transfer is I feel like is not yet ready. I don't know about May. Some people said May to me. I know some of my patients like, Dr. Luke, May, and I don't know. Because the embryo is safe. Yes, I do everything I can, and Dr. Nature and Genix, which will make sure the tanks are all filled up. But maybe July or June. I'm thinking, okay, don't be sad, but I think that is a lot safer. Why? And last I talk about COVID and IVF. And in the last segment, so sorry, some people text me. I just want to double check, making sure it's not. Oh, okay, it's all good. It is it's a very difficult time, and it also takes lots of thinking. I think every day, every motion I make, every decision I make is hard because before we all have habits. We just do go out, need masks, I have to wash. I'm like, where's my car driving? Where's the parking go? So I do think, some of you say, well, if I have high FSH and diminished ovarian reserve, can I try having sex? Is it okay? I think it's a very personal decision about sex. Yes, guidelines are saying no, don't try to get pregnant. And I think, let me explain from the guidelines or from the government agency why they don't want people to get pregnant right now, or why Dr. Luke, you're not doing embryo transfer. The reason is that, and also it may change in 2 weeks. So I'm doing this thing Tuesday and Thursday. So maybe by next Thursday, Dr. Luke talk differently. So don't be angry at me. But right now, as in 4/14/2020, Dr. Luke, what are you thinking? right now I hope we are at the plateau, and hopefully I heard from the other agencies saying, I mean not agency, but New York State government and Dr. Governor Cuomo, and is that hopefully we'll get over the hump. And if we are going to go better, but let's say right now we're still very busy in the hospital and so forth, and my husband just, um, we are, some of my friends and my significant other is at the front line. So they would tell, because right now the streets are very quiet, you can never see what's happening in the hospital. But it is still lots of patients in the hospitals, and why people don't do embryo transfer right now. Dr. Luke, why you're not just transferring? Well, the idea is that if you do get pregnant, right, or having a miscarriage or something like that, sometimes that may get you to a hospital. So we try to not have that happen. And also it's COVID-19, and there's always risk. I know it is a little bit more control better than a month ago, but it's still a um, uh, it's still a scary times for people. So I, at the same time, by common sense and logic, I always use common sense and logic to explain certain decision that patient making or I am making will be embryo transfer. Hopefully, will be June or July. In terms of restarting cycles, again, case by case basis, where patient with really bad FSH and they can't wait 6 months or 4 months. So we are really looking at safety wise. We're doing all the PPEs, and so those are case by case basis. But majority of patients we're trying to delay in June or July. But yes, we are patients. There are patients who are natural cycles and things they really want to get that egg, or the insurance and a lot of social reasoning. So I usually take it very personally and ask the patient, and very honestly tell you guys, hey, you guys are coming to the office and or going on the public transport or you even driving elevator. There's no guarantees, right? So that can, it's like you go in supermarket. There's no guarantees. There are always exposure and risk, and so and we always calculate risk and benefit. And at the end, patients say, oh, you know what, Dr. Luke, I will do it in July. You're right. Or no, Dr. Luke, because of da reasoning. And so we talk to each other. Um, yes, with diminished ovarian reserve, likely you can have and you may have a early menopause. So the curve of diminished ovarian reserve is from they basically the decline starts. I don't want to make you guys sad, but um, the decline of the ovaries actually. Okay, are you guys ready? It's at 20 weeks when you're a 20 weeks baby. So the peak of all of us having our ovarian as an identity is actually at 20 and 24 weeks while you're a baby inside your mommy's tummy. The decline of the eggs start happening then. We cycle about 400, I think 400 cycles each month. Excuse me, 400 in your each lifetime, and then you produce about one egg each month. So no matter how many loose circles on your ovaries, you only ovulate about one egg each month. Okay. And the decline is, I just told you when you were a baby, and actually when you were just, no, not even a baby, inside your mommy's belly. And then when you're a baby, it's still on declining. And then puberty is at the decline, but you don't really care about those eggs. But this is how science textbook teach us. Those eggs really don't have any clinical relevance to you. There's more biology. Someone like me who is a scientist studying about the ovaries, that I would love to know about those data. And also medical students or who are here right now as a medical student, or who are my doctor's friends, they love to know this stuff. At puberty, you're going to start, once you have a period, it means you ovulated. Oh, you grew and grow up to be a woman. Now you're able to get pregnant. Then sometimes at the beginning you don't ovulate every month. So like if you're an athlete, some of us in high school are athletes. We may not having menstrual cycle every month. Have a very irregular cycles, and then as you get older, you may start have regular cycles. The decline of egg quantity starts all keep on going. It happens, keep on going. Sorry to break to you guys, but again, we may not have any clinical difference, clinical significance. However, as you get older, as you go on to 25, this is where I start to talk about the quality talk. Majority of your eggs are still great at 25, 24. I was not ready to have a baby during medical school. I didn't even know I had money to buy lunch. I just told you I tutor and get a second job, get a third job to pay myself through medical school. So at that point, no way I'm ready for a baby. I want to study. I want to be a doctor. So majority of us may not be ready to get pregnant at 25. But the quality of eggs is very good. Okay, it's about, I always use a ratio, so it's 1 egg per month, so it's about 12 eggs per year, so it's about 8 to 9 good eggs in your 20s. As you get older, it's also 1 egg per month, so one more time, you may have a lot more eggs when you're younger, but you don't have 10 kids when you have sex. I always like this exaggeration so you can understand the concept. 10 years later, with 35, the quality starts to drop. So it's about 6 good six pack. I always say that to patients. You can still get pregnant. So lots of girlfriends can get pregnant. Dr. Luke, what if I have a less ovarian reserve? That's that equal to quality, which is another point that we'll make about if I'm younger, but I have a low ovarian reserve. What does that mean? That means that you may have a possibility to have a early menopause. Yes, it does reciprocate if you only had 3 follicles at 32. Yeah, you may have an early menopause. So that's point number one. Number two, does not mean you cannot get pregnant. So that is a very important point that we have. That does not mean that you cannot get pregnant. So you can still, like my patient who I told you was 35, 34, 36 with an AMH of 0.08 and got pregnant. So you can still get pregnant because the quality of eggs is still there. Do you have a less quality than patient your own age? That question I do not know, but I only know the biological clock. Your biological clock may be a little bit faster than another woman. So that means you may have an early menopause. So timing is important. I do not know exact quality of the egg. If a 32 with a lower AMH and a 32-year-old with a high AMH, do you guys have the similar quality or one has a lower quality than the other? That question I may not able to answer. However, by logic, the person who is 32 with a lower AMH, I would like you to tell you that let's get going, not wait too long. So then quality of eggs may be irrelevant at that moment in time because you are having sex, you're trying to get pregnant. If you don't get pregnant, we will come and seek my help. And yeah, I think the one would change is that if you do have a lower AMH and you're younger and you've been trying to get pregnant, you cannot get pregnant, then you should seek out to see a doctor sooner than later. Okay, some very good questions. Why would it's not true. It may happen to certain patients with DOR, and they may take longer. But lots of doctors, and this is why I give you an iffy, like I give you I don't know kind of answer to just now when I say image lower. Can that exemplify that the quality is bad? Some doctors do think it's true that your quantity is low, so the quality may not be as great. I'm not that I refuse to believe that. It's just that I don't want you to give yourself a diagnosis that you never get pregnant and you say, oh, I have bad eggs because my AMH is low. Because I also see lots of patients with AMH low or FSH high and they have sex and they can't get pregnant. So, if and no, great question. So one of the audience was asking if you are stopping medication that may not be good for the baby, and now we're waiting for transfers. Sorry, this may not be related to DOR or diminished ovarian reserve, but I will answer it because I'm going to wrap it up because I'm going to give the second part of diminished ovarian reserve talk next time because there's so much about diminished ovarian reserve, and maybe we'll go into more science about it. Today is more a preview, and I'm going to repeat some of the things that I mentioned today on that lecture. So don't be annoyed by me when I keep on saying, "Oh, Dr. Luke, you mentioned that already." Some of you get it, some of you not get it. So I may have to repeat that next Facebook Live. if you're stopping the medication, and this is really my advice because there's so much medication that are different. I have patients taking steroids, um, oh, actually no, inhalers for asthma and things like that. As you, I, because we don't know the timing of transfer and we don't know when we're trying to, I I usually right now I tell patients to continue all the medications they're doing per for their health of the med, because especially I don't want you to get sick. I don't want you to have some symptom. You have to go to emergency room, which is someplace we try to avoid if we can. So I usually tell all my patients to resume all the medication where they need it medically. Um, okay, and does psychological stress have a negative impact on the number of eggs that develop during egg freezing cycle? Um, Great question. Sometimes it does. It is true that during the egg freezing cycle, so stress is actually, it's like, some people ask me, does acupuncture has any effect? And there's some, when I was at Center for Alternative Medicine at Harvard, where Brick is very scientific. We love evidence-based data. So acupuncture was something new, and I'm very interested. As you know, I'm Chinese, and I always want to know does it help? And 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 why I'm mentioning this is related to a question about psychological stress. So acupuncture does have a placebo effect, been proven, many data. There's some data in Shanghai, they try to make it a very like legit, like a blinded study, no bias. And they say, well, it does have a 80% of the time, it does have a placebo effect. Means the patient feel better, less stress, happy. So placebo effect is an effect. Isn't that funny? So if there's an effect, I usually think it is, so effect is a good effect. So stress sometimes does have an effect because stress makes you sad, makes you tired, makes you discouraged. There's so many things that can happen. And I don't know, and I have not yet found data say, oh, because you're stressed, less number of eggs, or because you're not stressed, now you have more number of eggs. But interestingly, and this is again only my observation, not um, not a clinical data because I don't have proven, because there's not yet one more time a paper says stress less eggs. But there are certain reproductive diseases. It does happen in women who are stressed out. So some of you may know I did post in the past something called endometriosis. Endometriosis is about 10%, and my research is in on endometriosis patients. And I personally have endometriosis. If you follow my posts, I talk about endo strong and in my personal life. Um, and they did a study on endometriosis, which is an infertility disease in some way, where patients' endometrium tissue inside the uterus is growing outside. So you have pain during period, pain sometimes during sex, and pain during bowel movement. These are just clinical symptoms that you can have with endometriosis. You can also do not have this symptom and still have endometriosis. But it is a disease where stress, more high strung individual, I guess I am high strung, like type A personality, they always say, that can have endometriosis. I realize I can look in the camera, so I hope you guys don't mind. Now I discover it's this camera, not my little monitor. Sorry, I know. That will take a little bit of time to figure out. Well, so now I should look at the monitor to talk to you. Apologize. Um, so the endometriosis is a disease of stress. I mean, they kind of talk about it. Now, I don't know which way, which chicken or the egg first, right? Is saying that. So if you're stressed having endometriosis, or because endometriosis causes you more stress, but they say it's correlated. Means if you are more patient who have high stress women, they usually have high endometriosis. So since medical school is not a relaxing times and residency, lots of my colleagues do have endometriosis, and some of my colleagues do come to me for fertility care. Ha! So what happens to the and medical school? What happens with medical school? Well, I went to medical school when I was, I went straight and I skipped year in 1 year of college because of all the advanced placement I was taking. So even me, I was worried about because we don't practice until in our really mid 30s. And so lots of my friends, as I told you about quality of eggs, would need help with fertility. And some of them, and this is now to answer stress and quantity of egg. And sorry, I went all around to answer your question because there's no easy answer. Is that they're stressed out, they're also my girlfriends or medical professionals or who delay, and not just medical professionals, Wall Street, wherever, high stress life, they have endometriosis and sometimes and or diminished ovarian reserve. So I'm always wonder, can stress also hurt ovarian reserve? Um, so good. I am so excited. Um, I think I answered all the questions mentioned. You should ask how long the cycle will give you some indication. Me, my okay. Yeah. So cycle length is another clinical symptoms of ovarian reserve. Some women do as so. This is this is a great question, but I don't want to tell you because I want to. Do you remember last time? Ooh, today is long. Dr. Luke's session is too long. No, it's not too long. It's 1 hour. Do you remember last time Dr. Luke said text talk is only 18 minutes because your attention span. So I will answer this question very quickly, and then I'll keep some of the answers to those questions for next time. What about that? And then we can talk about diminished ovarian reserve. But yes, with shorter cycles, it does sometimes reciprocate that diminished ovarian reserve. But long cycles does not mean you have normal number of eggs. Okay, I see some more questions. If I didn't answer, what I would do it on Thursday. And right now it's between 1 and 2 o'clock. And if you guys want to sign on, maybe you can give me some ideas, one versus two, or it doesn't matter. I'm also trying to improve my presentation skill, engagement, want it being fun, want low key, and just basically try to give some empowerment education through this really difficult times for everyone, for the whole global humanity, I think. And so if there's any advice, I would love it because maybe something even after COVID, I would love to engage you guys once a week because it seems like I've been getting very positive feedback. Okay. Okay, guys, it was a pleasure. I will see you on Thursday. And right now we're thinking at 2 o'clock. I think 2 o'clock is good, unless 1 o'clock is more people versus 2 o'clock. But right now it's at 2 o'clock on Thursday. Okay, talk to you later and stay safe. And I can't and really again, thank you for listening and see you next time. Bye bye.